So then that brings up the next topic in the sense that what I want to really get at here, and that is patient expectations. Because we all deal with that on a day-to-day basis with what patients have heard about multifocal lenses from maybe their parents, if they happen to be the Gen X group, or what they've heard from other individuals in their lives. So what I would like is for everyone here, if you would, to maybe give our readers a pearl for setting proper expectations that you use in your practices for multifocal lenses.
I think the key is to know what your patient's expectations are, because the Gen X generation, these early 40 people right now, have different expectations actually than the baby boomers have. The Gen X generation, the typical Gen Xer, is going to be reading on their phone. You see them sitting on the airplane scrolling through their phone, whereas the typical, not those excluded here, but the typical baby boomer generation will have different media that they're looking at. So that is going to make a difference in how people use their visual system and what their expectation is going to be. And how much of an ad they're going to need and how early they're going to need it. So I think setting expectations, but understanding expectations from your different patient populations is critical. It's not just telling the patient or explaining to the patient what to expect, it's understanding that person and having them explain to me what they expect. It goes both directions.
I will be honest when I tell you, I simplify things to an extreme. And sometimes I do that because I want the patients to answer things on my terms that I understand where they're going with it. So I really simplify. And as my dad once said, we've done this enough now that we know what the patient is going to encounter that first week of using the contact lens. So I kind of give them a bit of a preamble to what to expect, so that way it doesn't sound like an excuse when any of these things happen. But I really simplify the patients. I go, there's 3 things I want you to pay attention to this week. How do you see far? How are you reading? And are you comfortable? If next week those 3 things are fine, we're on our way. Okay? And I tell them the first lens may not be perfect. I don't use will not. I don't use, I say may not be perfect. But that's okay. You're going to come in and say, doctor, I wish it was a little better here. I wish it was a little better there. But I create a situation where the patient understands that there's going to be some change here. There's going to be some dialing in and dialing down of what it is that you need. But I don't want them worried about when I turn my head real quick to go look at this, all of a sudden it went blurry. I want to keep them in some simple things that we can solve so that I can get them where they need to be, and usually that'll dial it down very, very well.
I think you're exactly right. Keep it to a minimal conversation. Make sure they understand, but here's why I don't talk to them a lot about it. I have the conversation, I try to set the expectations, but at the same time I do try to make it very simple for them, because this generation that's going into it, they don't want lengthy conversations about it. They just want it to work. They expect to be able to come in, you're the professional, fix me because I have another appointment in 30 minutes and I need to be out of here. They don't want a long drawn out conversation. They want to fix me and moving on.
Yeah, and to the point that the first lens or the first set of lenses may not work, and we know the number of how many lenses it takes. Letting the patient know ahead of time that we may need to do some modifications is also helpful for them. And as you said, bringing them back, I like to let them know that we're essentially putting the multifocal and the distance in front of their eye at all times, and it's not their eyes that we're trying to teach how to see, it's their brain. And it may be that over the course of the week their vision changes, and then when they come back after their brain has reset how they see, we're then able to modify that. That way they know that if something changes, that we have hope, that something's going to be fixed when they come in again, or we're going to be able to discuss it. So simplifying, absolutely, but letting them know that there may be some shifts and there may be some alterations, because it's not the eye, it's the brain that's really seeing through these lenses.
And so we basically tell patients 3 simple things. This is going to be a new visual system. You've been in a stage in your life that your eyes need a new correction, and this is a new vision system. We don't go in with the brain in the eye because I'm not sure how much it is brain versus eye personally. We tell them you're going to go through an adaptation period. It could be a day, it could be a month. Not sure where you fit, but you will have an adaptation period. And each time we see you, our goal together is develop a natural, comfortable vision. And those three things sort of set the stage. And where I find a lot of doctors are falling short is either the patient comes in and says, I don't see very well because they didn't explain this, and they don't take the time to, we can talk later about the fitting techniques. Well, again, you start the process as soon as you're moving somebody out of their full distance prescription. I truly believe you start it early, very early. And I think, when you've seen one multifocal patient, you've seen one multifocal patients. They're all so different. As you're learning to fit multifocals, you realize in the right hands, 85% of your patients are going to be, in the right hands, 85% of your patients are going to be happy in a multifocal, much more happy than monovision. You've done the best, they've done the best. So, it's sort of a doctor philosophy. I am a contact lens specialist. I am going to fit multifocal lens, like Dave said, have this assumptive philosophy, and it's pretty simple.
John, I actually think that that it does matter when you fit. I think it's pretty significant, as Jack was saying, and I don't wait until a patient needs the presbyopic correction. I don't wait until quote unquote 40 hits and presbyopia starts, as many of you do and most of the readers do. Our patients are on their computer for 8, 12, 14 hours a day, and then they go home and they read their iPads and their iPhones. And so there's so much of the issues related to eye strain and discomfort that we're moving our patients into multifocals in one way or the other very early, in their 30s.
I want to take this a step further.
Sure.
And I want you to comment on this when I get through. But basically, it's the how and why and when of introducing a patient to this new, different modality than what they had before. In other words, do you discuss this with them before the symptoms appear, as they're really emerging into presbyopia, or do you wait until their symptoms appear before you discuss this? Do you prepare them in advance, or do you basically wait until everything it comes out? Should we be proactive or reactive? And I think I'd like you to just comment on that first.
Yeah,
and we'll take it.
Absolutely being proactive. I mean, our patients are coming to us for the best treatment that's out there. And I think we're all comfortable in the eye care world of prescribing spectacle glasses to our patients for their computer use. I mean, I do it on an everyday basis to my spectacle wearers. A separate pair of glasses for their computer and for their distance and their sunglasses. Nearly everybody walks out with 3 pairs of glasses, whether they're 45 or whether they're 35. And it's all dependent upon, of course, what the patient does. But those patients that are on the computer all day, we ask, how do your eyes feel at the end of the day? And sometimes the dryness could be signs that their eyes are fatigued. It's not necessarily just the dry eye, because their blink rate and so many other factors. So we start moving those patients early on, and we discuss with them, you're sitting at a computer all day. If you were playing basketball all day, you wouldn't be having 1 pair of shoes. And we need to have you have a pair of contact lenses that are specific for the activities that you're doing all day. And these contact lenses reduce the amount of effort that you have to put in at your computer distance. And the patients get it. They don't think, oh no, I'm getting old, I have to go into bifocals like my mom or dad. The patients realize, oh, my doctor sees that I spend 8 hours at the computer and then 5 hours at home on the computer. He's prescribing glasses or contact lenses for me specific for those activities. And when you get specific prescribing, when you're doing specific activity prescribing, patients get it and they see a value in it.
Some clues to whether they're having problems are going to be your comfortable wearing time. Are they decreasing their comfortable wearing time during the day? What they're doing when they're, during the day, all day long. All of those are nonverbal clues that they sometimes can give you if they're sitting in the room holding their iPhone or things like that. All of that will lead to whether you need to have that discussion earlier. But I think it's important to bring it up even before they are actually having the problem. The other thing is your patients can give you clues. It's not necessarily about vision. They might be able to see clearly, but are they comfortable? And asking comfort issues, not just about eye strain, but does the back of your neck hurt?
Absolutely.
Does your shoulders hurt? Other body aches that they may have actually may point to the fact that they are having some vision issues maybe how they're holding their posture, they're leaning in or they're sitting back, they're not ergonomic while they're on the computer, and that actually may be a vision problem. And so asking those questions can help lead to whether you need correction
Can I ask
earlier.
a question? Oh, go ahead, I'm
So
sorry.
what you're really saying here is you're planting the seed at that point as well. It's not just...
I call it looking in my crystal ball. I will look in
Right.
my crystal ball to the patient when they're 35, 36 and say, hey, look, I'm already blah, blah, blah. What you're going to notice over the next couple of years is this is going to happen, that's going to happen. Don't worry. There are plenty of options for you when those things happen. You're not going to stop wearing contacts. You're not going to start having a line on your glasses. There's plenty of ways that we'll be solving that. It'll be moving you into newer and better technologies. And so even if that patient is not being fit today,
Right.
they know that there is something that I'm going to talk about when, I'm like, do you notice this now? Computer strain this, that. No. Okay, the day that you start to really notice that, I've got options for you. We'll talk about it.
But it also brings the patient back to your practice.
Right.
It ties them to your practice. Oh, I'm going to go back to you because I know that you can help me on
Right.
this.
Or regardless of how you set the table on talk, we all are communicating with our patients, whether it be at the moment that they have the presbyopic issue or preparing them for their presbyopic issues. We all seem to have the same thing, which communication is key in all of this. The more you communicate with your patient, the more they're likely to stay with you, because the last thing you ever want is to have that patient at dinner with their friends and their friends are more informed about their issues that are coming up in their eyes through their doctor than through you.
Right. And that's a good point, is that presbyopic patients or pre-presbyopic patients are likely to have friends of the same age. And somebody might be complaining, oh, my doctor has something for that. He or she just talked to me about that. I get that all the time, where people sitting in my chair and they're like, oh, Missy told me I had to come see you. I'm like, oh, say hi to Missy.
Yeah, exactly.
Whoever Missy is.
Whoever Missy is.
Whoever Missy is.